Morning. Morning, everyone. Good morning, Caroline. You're going to get sick and tired of seeing me. Spent the day together yesterday talking anatomy. So, yeah, and then more anatomy. What else do you need in life? Good morning, everyone. Welcome. Nearly the end of 2025. Good morning. Yeah. Happy Mondays indeed. Yeah, so we are moving on to the last area of the thigh before we move into the pelvis area. So that's the plan for today. We kind of finished up last week. Morning, Becky. Morning. I haven't seen you for a while, or I've just missed you. Apologies if I have. Right, let's have a look. Morning, Tris. There we go. Let's get rid of that. Okay, last bit. So anterior thigh. Just a bit of a recap then. So the thigh is split into compartments, just like the leg, and each of those compartments have got an attachment into the femur, onto the periosteum of the femur, and they divide the leg into these sections. So that's what I've tried to do with how you learn all the muscles, and it will help you when we get to the blood supply and the nerve supply for those regions, because on the whole they have a singular supply. Some of it's shared, but if you kind of remember the compartments, then most of it makes sense. So yeah, we're looking at the anterior thigh now, and there are some key muscles in here. We were talking about these yesterday on the course that I was doing with Caroline. So we'll teach a biomechanics of exercise day, which is yeah, it's pretty heavy on the anatomy. It's analysing a movement basically, and working out what muscle does what and when, and what kind of contraction it's doing, and all sorts. So yeah, and then linking it into a clinical picture as well as a functional one. So but I think once you understand all of that, understand it just takes ages to kind of get your head around it. But as long as you have that concept of how things work, then it then becomes a little bit easier to work out how things get injured, and if you're dealing with that kind of stuff, or how to exercise things if things need rehabbing, or just training in general. So the rectus femoris has two attachment points. So we've got two parts of the body, two joints that it crosses, and because of that, the rectus femoris is the more likely quad muscle to get injured if it does. Usually it's around about this area here. So you can see on the image there, it's highlighted in yellow. This is the Complete Anatomy app. So when you click on a muscle, it then highlights it in yellow. Really good app if you want to get a 3D understanding of the body. And yeah, I've got no vested interest in it. It's just a good app. So we've got the muscle fibers here, so we can see these kind of different directions of the fibers there, and then this area here is a different color. So this is the tendon as it's coming down into the tibial tuberosity just here, and then up here, if we have a look, it connects onto the AIIS. So when we had a look at the bony landmarks of the pelvis a few weeks ago, we mentioned the AIIS as well as the ASIS. And so those are the ASIS is the anterior, so at the front, superior, higher iliac spine, which is this area here. So it's the front high bit of the iliac spine. The AIIS is the anterior inferior iliac spine. So it's at the front, but it's the one below. And that is where your rectus femoris attaches. There are, however, two attachment points for the rectus femoris. It's kind of split. So you've got AIIS, and then there's a little offshoot that comes around to the top of the acetabulum, which is the socket. So we'll have a look at that as well when we have a look at the videos in a second. So if we think about what happens in a squat type movement and just focus on the knee for now. So you're standing upright, like in this picture here. So at that point, this part of the quadricep or the rectus femoris in this point is in a shortened position, and then this point up here is also, well, it's a bit more lengthened at that point. So you have to kind of divide the two into the muscle into two. And then as you sit down, so you go into a seated position, the hip area will start to get closer together. So this part will shorten, and then the knee will start to flex. It will start to bend. So the tendon has to go over the joint, so it will start to lengthen. So it does the opposite, standing up to sitting down. So what we've got happening with this muscle when you do a squat type movement is basically no movement of the muscle. So to lengthen it or shorten it at one particular point, you'd need to have the other bit to stay still. Yeah, so if you kept the hip part still and bent the knee backwards, so heel towards your bum, then the rectus femoris would stretch. Yeah, but then if you leant forward in that position, then it would shorten the top part of it. So you can play around with the angle of the pelvis and the angle of the knee to change the type of contraction that you're going to get on that muscle. And the same happens with the hamstrings as well. So if you flip it the other way around, when we were looking at the hamstrings the other day, the hamstrings attach onto the ischial tuberosity. So as you bend forward from the hip, that hip portion, if you like, if you're going to kind of divide it into those half sections, just make it easier to understand. So that hip portion, as you bend forward, that's going to stretch. Yeah. So like doing a deadlift. And then if you did a Nordic curl, so you had your heels tucked underneath the bench and your body upright like that, and then you lean yourself forward, then the knee portion is lengthening eccentrically. So you're getting this lengthening of the muscle. But when you do a squat, again, when you're stood, the knee part is lengthened, the hip part is shortened, and then as you bend the hip, that will start to lengthen, and then as you drop down into a squat, you bend the knee, so the distal part shortens, and again the hamstrings stay roughly about the same length. Yeah, so because they cross two joints, we've got this kind of, it's like a isometric but moving contraction. It's really hard to get your head around when you first kind of think about it. It's like, oh my god, yeah. So when you're upright, this bit's lengthened, this bit's shortened, but then when you go down into a squat, it just flips. So does the muscle actually lengthen or shorten at all? But when you go into a squat, so it's the hamstring part of it. That's what I know it from. If you've never heard of it before, it's called Lombard's paradox. So you can have a little bit of a look at that if you want a bit more of a better explanation than what I just gave. It's easier with when you're demoing exercises, I think, than talking through on a static picture. But hopefully you get the idea. So one of the reasons why the hamstrings and the rectus femoris is likely to get injured is because of that unique way that it moves. There's a lot of load going through that muscle from both ends. So that's what, yeah, usually it's a rectus femoris tear if you tear a quad, and usually it's biceps femoris if you injure a hamstring. That's the one that's more likely to get injured. So yeah, there you are. So that's Lombard's paradox. Tried to be explained. So rectus femoris then, let's have a look at that on the videos. Bear with me a second to just bring that up. Here we go. It looks as if my videos are working all good this time, and I can pause them, which is good. So there's your rectus femoris, and again, I've said this a few times. So these models on the Ackland anatomy videos, they are usually, well, usually donations to a lab are elderly people. So you would expect somebody who is younger to have a lot bigger thigh muscles than this, a lot bigger rectus femoris. But obviously young people don't often die young, so we don't really usually get them in the labs. It's usually elderly people that we get, so that's why the muscles look a little bit smaller than usual in most of the time. So yeah, there's your rectus femoris, and then we see it as it comes up here. See, we've got a bit of a split. So there's your acetabulum, there's your AIIS just up there, and then there's the attachment point just there. Just going to move some stuff for me so I can see better. There we go. So there's your AIIS, and then there's that little slip that I was talking about before. So it's a little bit that it's kind of like a two-headed attachment up near the hip and pelvis. So this is where it all comes together at the knee. So at this end here, before it gets to the patella, this bit here is the quadriceps tendon, and then you have the patella, and then it turns into the patella tendon, and it's all obviously one continuous bit of tissue, but we kind of divide it based on where the patella is. Okay, vastus medialis is here. So this is vastus just means big, medialis means towards the midline. So this is on the inside of the knee, and sometimes this is called VMO because of the oblique fibers. So vastus medialis oblique. All right. So, but rectus femoris sits in between this vastus muscle here, which we'll look at in a second, and then this one here. And it's the most superficial one. There are some little, well, there is a little muscle underneath this. I think I've got a slide on it, but if not, I'll talk to you about that in a sec. So we've got, quadriceps tendon, and it's usually this area here. So where the muscle turns into a tendon, that's usually where you get your injuries. Okay. So let's just go back again on that. Yeah, so rectus femoris there, and then there's the split. Can you see that little kind of, it's like a Y shape there of the tendon. So you can see it coming up just above the acetabulum, so there, and then AIIS just there. So that's your rectus femoris. And then other muscles in that anterior compartment, we've got all that act on the hip anyway. So the vastus muscles, we covered those in the knee because they don't cross the hip. All right. So if you want to know a little bit more about vastus medialis, vastus lateralis, those are in a previous knee video. So go have a look back at that. This one's a really controversial muscle, shall we say, especially in the therapy world, because it's really quite deep. Okay, and there's on a very, very thin person. So for example, I used to treat some really really good long distance runners, and they were super skinny and really athletic, so had really good musculature, and from the front of their body, so through their abdomen, yeah, there wasn't much room, and you could push through and you could feel the bones of their spine. Yeah, and that they were that thin. So I think you can palpate this area, but there are lots of layers in between. Okay, and there have been some MRIs done where you push into the abdomen and you can make an indentation into the psoas muscle. However, knowing what we do about manual therapy, you don't need to have an effect on this region. You don't need to push through into someone's guts. So we've got a lot of tissue overlying this area here. obviously on the skeleton it looks easy, doesn't it? You can just kind of access that muscle, but you've got intestines, small intestines, large intestines. Tucked up underneath here you'll have the liver, so as long as they've got a normal sized liver that isn't descending, then that's all good. You've then got the musculature that keep all of those abdominal contents in place. So transverse abdominis, internal external oblique, rectus abdominis, all over the top of that. Then you'll have a subcutaneous fat layer, then you'll have the skin. Okay, so all of that is over that region there. Now, one of the reasons why somebody might want to treat this muscle is because of a test called the Thomas test, where when you lie on your back, your knee is raised up, and we call that a hip flexor contracture. Okay? So basically, if you think about it in the simplest terms, this muscle, because if we have a look at what it does, is it will flex the hip. So the theory is if there's a contracture in this muscle, then it will limit hip extension. So you won't be able to bring the leg backwards. So if you were to simplify manual therapy and say, right, in its simplest form, what we're trying to do by working on psoas is to improve hip extension, you can do that without digging through somebody's guts, and it's an uncomfortable technique. It's just not very nice. It can be really painful, and the likelihood of you being able to directly affect it is really slim. Okay, so if we think about the whole goal of why you're doing it to improve hip extension, there are loads of different ways that you can do that. So the easiest thing when I teach the manual therapy to sports massage guys from the very off is, right, our goal is to help with hip extension. We don't need to, we can't just target one specific tissue. So if you lay your hands on someone's skin over the abdominal region, you will stimulate the nerves in that area, which will assist in, and you retest hip extension, so they do the Thomas test again, and it will improve if it is a neurological issue. Okay, so you don't need to do it. It's not necessary. There's loads of other ways that you can affect this region as well, and just the fact that on some people you can do it doesn't mean that you should. Okay, so but it's become one of these kind of like bit of a macho muscle to target, really. Yeah, Jesus, where there'd been so much focus and demonization on the psoas, where did it come from? There was a book that was written that this psoas contained like anguish and stuff like that, and yeah, I think it's that kind of, I don't know. I think that there was literally a book. I can't remember the title of the book, so somebody can Google it and have a look for me. But it was something to do with specifically the psoas muscle containing lots of kind of emotion. I can't remember the exact title of the book, but I think it stems from that, and it stems from sports massage courses that have been taught over the last 20 years because they had a very mechanistic approach rather than a neurological one. So basically, if hip flexion's tight, it's got to be the psoas. There's so many other structures that can limit hip extension in this area. So and the fact that you can target a specific area. It's a bit like piriformis. We looked at piriformis the other week, and there are so many muscles around that area, you can't call it a piriformis syndrome. Whereas you can't say that digging into someone's abdomen is specifically targeting psoas, because you will affect every single structure on your way through to where you're trying to target. Yeah, so through the mechanoreceptors in the skin, mechanoreceptors in rectus abdominis, transverse abdominis, internal, external oblique, all of the receptors around the guts, yeah, the fascia that's around that region is innervated. So that there's so many different structures, but then we go, oh yeah, we targeted psoas and that's why it helped. So I think that's probably it. It's just made it a bit too simplistic. But the thing that people miss with this muscle as well is this bit. It's a lateral rotator. Okay, so when you do the Thomas test, sometimes people don't do it quite right. So what will happen is you'll lay back, and if you don't know what the Thomas test is, then just have a look. Liz Cock. Okay, thank you. The vital psoas, that was it. Yes, thank you, Joanna. Yeah. So I think it comes from that. Yeah, I think it comes from that. Yeah, so the thing that people miss with the Thomas test, when you're lying on your back and you lower someone's leg down, sometimes you'll notice a lateral rotation of the thigh, and then they're able to lower their leg all the way down to the top of the couch. The issue with that is because you get lateral rotation from the hip flexor, yeah, from the psoas. So really, you want to limit hip rotation. So you want to keep, or femoral rotation. So you want to keep that femur in the midline as you bring the leg down, and it will, and it really does change the test. So it goes from a negative test if you allow the leg to just laterally rotate into a positive test if you keep it in the midline. And all you need to do is just an MET in that position. You don't need to go dig around in people's guts to do that. And if there is an issue with the musculature, then an MET will sort that out pretty quick. Yeah, if it's a neurological problem. So yeah, that's and it's because of the attachment point there on the lesser trochanter. Because it goes underneath the femur, if it's contracted, it will spin the femur, okay, in that plane of motion, in that sagittal plane, it will spin it. So yeah, to make the test a little bit more accurate, you'd need to maintain that kind of neutral alignment, if you like, of the thigh as it comes down. Cool. Right, let's have a look at that. So this is your psoas. Yeah. One to buy for Christmas for Tristan, that book. We want to see him in a fit of rage on Christmas Day. So there's your lumbar spine, and there's the psoas coming over. So sometimes it's called the iliopsoas. So we've got because it does join up with a muscle called the iliacus as well. So we've got iliacus, sometimes pronounced iliacus. There's only one person I've ever heard call it that, but iliacus sits in here, and then it joins with the psoas major, and both of them join at that lesser trochanter on the femur. So it attaches onto the transverse processes and the discs and vertebral bodies. And again, this is one of those ones that is really blamed for lower back pain. And again, it's just too simplistic to say, oh yeah, psoas is the reason why you've got a bad back. It's because of an anterior tilt. It's just a nonsensical argument. There's also the lower cross syndrome problem, where the psoas is blamed again for an anterior pelvic tilt, so tilting your pelvis forward if psoas is tight, and sitting all day makes your hip flexors tight with your psoas and iliacus. So if you're at a desk for 8 hours, yes, you're sitting for that period of time. During that period of time, I don't sit there with my arms dead straight like this either and just dangling by my side. I bend my elbows and rest them on my desk. So why don't my biceps get really tight like my psoas? I don't know. And then also, if I get a good night's sleep, I've got 8 hours lying on my back. So if I've got 8 hours at a desk where I'm scrunched up and shortening my psoas, surely if I sleep, then it will lengthen my psoas. I don't know, that maybe that's just too logical. And the fact that one thing can't cause back pain, there's lots of different reasons. So yeah, these are the these are the attachments on the discs and vertebral bodies, and then it goes down into the lesser trochanter down there. Let's just play that through. So I'll add the muscles on in a second. Okay, so lumbar spine, and then, oh, that was it. I thought that was, hold on, is it the first bit? Ah, there we go. That's the one I was after. We'd already seen it. Okay, let me just pause that there. So here we go. Those are your attachment points there. Okay, so that's all your transverse process and vertebral bodies and discs. And then see that muscle behind? That's your QL. Yeah, when I first started learning this stuff, I was thinking, I imagine QL to be massive, but it is quite small. And then there's your iliacus all in there. See the iliacus coming over, and it does join up with the psoas major. Okay, so iliacus then looks like this one. Okay, so it fills all the inside of the pelvic brim. Yeah. So this is called the iliac fossa, and it's got a conjoined tendon, so they both join together and attach down onto this lesser trochanter just here. So this muscle is a really powerful hip flexor, yeah, because it only crosses one joint. It's got a really stable base. The psoas is working on the movements in the spine and in the hip. So we've got a similar situation going on here with the psoas because it's crossing, well, it's crossing multiple joints because we've got multiple joints in the lumbar spine, in the sacroiliac joint, and over the hip. Yeah, so there's a lot of stuff going on with that psoas. Iliacus is literally bang, iliac fossa, lesser trochanter, that's it. And the broad spread of this muscle makes it really, really powerful. Okay, so it is a very good hip flexor. Let's have a look at it. Here we go. So this is iliacus in the anterior part of the thigh. Well, that's a better image. That's the kind of thing that I was looking for on the last one. So there's your psoas. Okay, that's your spine just there. And the cool thing with that is you can still see the ligaments on the spine. We're going to cover that when we get to the spine, but that's your anterior longitudinal ligament just there. So but the cool thing is you can see how it kind of weaves into everything. So on the models where it's just got those spots and it goes, yep, psoas attaches here and then it attaches here and then it attaches here, it just spreads and wraps around every, and then merges into another structure, and then carries on with another one. So yeah, your psoas major just kind of glues itself to that lateral part of obviously on either side of your spine. There's your iliacus just there, and then it comes down and they both join together into the lesser trochanter. So let's have a look at that. So there's the iliac fossa. So fossa just means like a shallow or a dip. And then here it comes. So over here. So it's coming over this area here. So the inguinal ligament is over the top. There it is. So it goes underneath that inguinal ligament. If I just pause that there actually. So the inguinal ligament, and we've covered it a little bit when we had a look at the femoral triangle, but the inguinal ligament forms the floor for the abdominal wall, So the abdominal wall will attach into the inguinal ligament. And when we do that region and we have a look at things like herniations that around that area, so inguinal hernias, they you'll see that it's just completely covered in connective tissue, in fascia. Okay, so that's, again, doesn't look like this when it's all together. In fact, let me just pause that very quickly at the bottom. That went really quick then. So there, just poking through there, that's your lesser trochanter. But you'll see what they need to do to expose it. They need to laterally rotate the hip so that you can see it. And that's what these muscles will do. Okay, so they'll hip flex, but because of where the lesser trochanter is underneath, it can also spin the femur. Yeah, so you'll get that lateral rotation, which is why you need to look out for that. There it is on that Thomas test. Okay, so that's iliacus, and then we've got one more, which is the sartorius. So sartorius is named after, it's called the tailor's muscle. And years ago, when tailors used to work, they used to work cross-legged. And because of that cross-legged position, they would have an overdevelopment of this muscle because the action of this muscle is flexion, medial rotation of the knee, flexion, abduction, and lateral rotation of the hip. Yeah, so we've got that flexion, abduction, lateral rotation of the hip. That's crossing your legs. Yeah, so if you spend your working life with your legs crossed, you will have a very well developed sartorius. That should be ASIS, not AIIS. Apologies. So that attaches on the ASIS. It's the rectus femoris that's on the AIIS, and then it comes down all the way down here into the pes anserinus. And we've seen that before when we looked at the knee. And the group of muscles that attach into there are your Sargent group. So it's your sartorius. So this one, gracilis, one of your adductor muscles, semitendinosus, so SGT, and semitendinosus, one of your hamstring muscles. Okay, so all three of those attach it into there. And because we've got three going into there, the attachment point looks like a goose's foot, which is what pes anserinus means. Okay, so that's why it's called that. So this is the goose's foot just here. Can be a really tender area just because there's lots of attachments of muscles in there. And I did a little bit on differential diagnosis around the knee, because sometimes you can get fluid coming out of the knee leaking underneath these tendons and making that area quite sore because of the pressure. So you think it's a pes anserinus problem, but actually it's coming from the knee joint itself. So you need to have that as part of your differentials if you're looking at the knee. So let's have a look at sartorius. Here we go. So here we go. So there's your psoas, there's your iliacus, there's your sartorius there. So really long muscle. And remember, this formed the border for your femoral triangle. There you go. Okay, so it comes across here, all the way across the top. Now, I was teaching sports massage the other day, so I've got to do a couple of one-to-ones with students. And one of the things that they've noticed as they've been massaging the quads or over the anterior thigh is a flicking. Okay, and they're like, "What's that flicking?" So we did a bit of anatomy digging, and you go, okay, so this muscle crosses over here. So if I'm massaging up or down the leg and I get this kind of flick over, it can be the sartorius that you're flicking over, because as you're going in that direction, yeah, you're then going to roll over those fibers of sartorius. And that's quite a classic one where you'll get this flick. So yeah, obviously if it's tender, then it's not going to be very nice if you do that. Okay, so just be aware of sartorius there. So we've got ASIS, and then it snakes down and then onto the pes anterine, just there. Okay, so remember Taylor's muscle, cross-legged seated, it's that kind of action that the sartorius does. Right. Okay, then we're on to last bit. We've covered a little bit of this already because we looked down at the knee portion of these muscles. So these again cross two joints. So just like rectus femoris, but it's the opposite way around. Yeah. So when you're stood up, this part of the tendon here is going to be relatively short. This part of the tendon here is going to be relatively long. Yeah. And then as you, so if you're there like that, I haven't got enough bends in my hands, but let's do the hip first. So if I'm there and sartorius is coming over this area here, as I bend the hip, that's going to lengthen that top part of sartorius, semimembranosus, apologies. So semimembranosus is going to, so one of your hamstrings is going to lengthen around your bum. Yeah. And then, well, let's make this bit your knee. All right. So as the knee bends, that bit's going to shorten. Yeah. So we get that kind of action there. Yeah. So from there, hip bends, that will lengthen. But at the same time as you're doing that, because you're bending the knee, this bit's going to shorten. And then you'll sit. And then when you stand up, the knee part is going to lengthen and the hip part is going to shorten. And the relative movement of the hamstrings is pretty much the same. Okay, so it's like an isometric contraction for the hamstrings when you do a squat. Okay, so again, just something to blow your head off and have a think about. Here's semitendinosus. So again, it attaches ischial tuberosity, so your sit bones. And if you're not too sure where they are, you've not really done this before, if you sit on your hands and you have a bit of a wiggle around, the bits that are bony that you can feel, that is them. Okay, so that's where your hamstrings attach. And then all the way down here, it attaches onto your tibia. And it's the pes anterine, which is what we were just talking about. So that's your semitendinosus. Okay, so sartorius, gracilis, semitendinosus, all attaching that same point. Oh, my phone's going. Apologies. Let me get rid of that. Don't need that. There we go. Yeah, so sartorius, gracilis, semitendinosus, all attaching on that point there. And then your last one of the hamstrings is your biceps femoris. Now, this is the one, like I said, that usually gets injured. So we've got two heads on this one, hence biceps. So bi is two, seps means heads, and femoris is femur. So two-headed muscle on the femur, and this attaches down here onto the fibular head. Yeah, so on the back of the fib just there. The short head will attach onto the back of the femur, and then there's that linea aspera on the back. There we go. So linea aspera. Which is the white line at the back of the femur, and then the long head attaches onto the ischial tuberosity. All right, so again we've got the majority of the muscle crossing two joints. There's this bit of it that doesn't, just crosses the one. So again, all of these muscles together, all of the hamstrings, so biceps femoris, semimembranosus, semitendinosus, they all will have that lengthening and shortening at the same time when you go into a squat. Okay, so that's, like I said, that's Lombard's paradox. So let's have a look at your hamstrings. Just get this one up, not that one, that one. Okay, so this is just a broad look at the hamstrings, and then we'll have a look at it in a bit more detail in a sec. So these are your tendons coming down here. So semimembranosus, semitendinosus. Tendinosus is on top. We covered this when we looked at the knee. So this is obviously the knee portion. The semimembranosus, semitendinosus are on the inside, so they're medial. and then biceps femoris is on the outside. Okay, so that's more lateral. So biceps, 2 heads, femoris, femur. So 2 heads on the femur, and it attaches onto the fibula head. So that's just a bit of an overview. That's what we've seen already when we looked at the knee, and this is it in a bit more detail. And this is perfect timing, because what we'll do, I'll just pause that there. What we'll do next week, we'll start the pelvic floor next week. Okay, so we'll finish off all the thigh today. That'll be perfect timing. And then, yeah, we'll have a look at the pelvic floor muscles as a standalone session next week. Cool. Okay, it's Tristan's favourite session. You know that one. Okay, let's get rid of that. Don't know why that's showing up. Here we go. Let's have a look at this one. Okay, so this is having a look a little bit further up now. So we're looking towards the ischial tuberosity. On the last video, it's down by the knee. There's your ischial tuberosity, greater trochanter, just up around there. Let's just follow these down. So your semimembranosus, semitendinosus are medial. Biceps femoris is lateral. Okay, so and there's your vastus lateralis around there, which we looked at when we looked at the knee. So there's semimembranosus, and the reason why it's called semimembranosus is because it is half membrane. Yeah, so we've got this long, fat, flat membrane, and then the muscle belly just starting around about here. Yeah, now you know that. Semitendinosus means half tendinous. It's because it's got a really long tendon. All right, so there's semimembranosus just there. That's where it attaches, ischial tuberosity, and then onto the back of the tib, posterior condyle of the tibia. And then here's semitendinosus. So we've got a longer muscle, a lot more muscle belly, and then a really long tendon there. Yeah, so half tendon, semitendinosus. There's your attachment, ischial tuberosity. And then that famous pes anserine area there. So that's your Sargent group again. Sartorius, gracilis, semitendinosus, all attaching in that area. Goose's foot. There's your biceps femoris, so the most lateral one. This is going now to the fibula, down to the fibula head. So there it comes down here. So this is your long head, which attaches onto the ischial tuberosity. Short head starts lower down on the femur. So there's the long head attachment. There's the short head attachment just there. So that's your linea aspera. And then it comes down here as well onto that condylar ridge. And then both of those then join together to form this tendon. There we go. That's them together. And then they attach onto the back of the fibula just there. Okay. Cool. Brilliant. Right, let me just get rid of that. Get rid of that. Bring that in. That went really quick today. So yeah, pelvic floor next week then. So we'll do pelvic floor. We'll do a little bit of a recap of the thigh. Move on to the pelvic floor, and that'll probably take us a session as well. And then we'll start having a look at the blood and nerve supply for the area. As always, if you've got any questions about anything we've covered today, if you want point, especially all the psoas stuff, because that can be a bit like, oh, I didn't realise that, I was taught something different, give me a shout and I'll show you some decent resources to have a read of. And yeah, if you've got any questions, pop them in the Facebook group as usual. So Tristan just said, got a client with exactly that, thought it's pes anserine bursa, but also wondered if it was knee joint. Sweep test needed, I think. Yeah, you can do that. And if you're not too sure, you can get imaging done. An ultrasound scan will show up fluid coming out of the knee, but it won't tell you where it's coming from. So usually the ultrasound and then MRI if there is fluid coming out, and then it will tell you what's going on if there is anything coming from the knee. No problem, Becky. Thank you, Caroline. Cool. See you next week.